London Losey. I am one of 2 training coordinators with the Minnesota Department of Health Family Visiting Program. I'm pleased to welcome you today to the webinar Information for Home Visitors on Newborn Screening and Immunizations during the Prenatal Period through age 2. To discuss today's schedule, we want to bring to your attention our intentions behind combining the topics of newborn screening and immunizations in the same webinar. First, when thinking about the time in which to introduce the topics of newborn screening and immunizations, the prenatal period is really ideal. Upstream messaging during the prenatal time period, when pregnant women are forming their health beliefs about newborn screening and immunizations, will influence future healthcare decisions for themselves and their babies. In addition, home visiting staff are trusted health educators for pregnant women and their families. Home visitors can quickly deliver key messages about the importance of newborn screening and immunizations and refer their clients to trusted resources. Our webinar is really 2 separate presentations on topics that can be addressed around the same time period with parents. Our presentation by certified genetic counselor Maggie Drion will address newborn screening for family home visitors. After Maggie talks, we'll take a short break, followed by a presentation by Lynn Bada on immunizations and pregnancy. Your phones have been muted during the presentation, but you're welcome to type chat questions in the screen at the right. We will also open up the lines after each presentation to allow for verbal questions and answers. One thing to let you know is that we are including a series of polling questions in today's presentation. Your participation is appreciated, and you can do so by responding to the questions that pop up near the chat window at right, and submit your response in the given time frame. In addition, today's webinar is being recorded for those who cannot participate today. With that, let's get started. Here's Maggie.
Well, hello, everybody. Thank you for taking the time out of your day to be here with us. Again, as London said, I'm a genetic counselor with the Newborn Screening Program, and today we're going to talk a lot about what newborn screening is and what your role within that will be. Our brief agenda is to give you an overview of newborn screening, the details of it, so you actually know what it entails. We'll talk about some legislative updates because we've been in the news a bit because of some lawsuits that happened. So we'll update you on what the current status is with regards to our storage and retention of data. We'll talk about the role of family home visitors in newborn screening education. We do have a modeled conversation with your clients, and this is just an example to give you guys a place to understand what from this do I really need to be able to have at the tip of my tongue, and what can I kind of refer to resources for. And then obviously we'll take questions at the end. So the first question we have is, are you familiar with newborn screening? And I want you to answer A, very familiar, B, somewhat familiar, or C, not familiar at all, or I've never heard of it. I'll give you a second to submit your responses. Once you click a link, then want to submit it at the bottom so that we can see your answers. We're going to close it just a couple of seconds here. See that some of you are very familiar. It looks like 50% of you say you're somewhat familiar, but nobody said they had never heard of it, which I love to see. Obviously, again, our goal today is to take those of you who either aren't familiar or who are somewhat familiar and to increase your level of understanding and comfort with newborn screening so that you can feel more comfortable in your discussions about newborn screening. So one of the big things that we really want to talk about is what is the newborn screening experience. And oftentimes people simply refer to it as the PKU test. And when they talk about newborn screening, they're really referencing the blood spot component. But there's actually 3 separate components to newborn screening, and all 3 of those components make up the entire experience of newborn screening. So the blood spot is oftentimes one that people are most familiar with, and I will go into each of these in more detail following this. But the blood spot is where we're looking for greater than 50 conditions that have some sort of treatment or cure. The second part is hearing, where we look for loss of hearing in the range where speech is heard. And the third component, and newest, is actually pulse oximetry, where we're looking for critical congenital heart disease. Because there's these 3 components that are part of newborn screening, referring it to the test as the PKU test is really no longer accurate. It was understandable that people used to call it that because when we started screening, that was the only condition we were looking for. But in the 50 years that Minnesota has been doing newborn screening, we've obviously added quite a number of conditions to that panel. And it can confuse families if we call the test the PKU test and then it comes back positive for something else. So we really are encouraging people to use the language of newborn screening when they're referring to all 3 components that make up the entire experience. The blood spot is one of the 3 components, like I mentioned, and where newborn screening started. The blood spot is collected between 24 and 48 hours after birth, and it's done through a heel stick on the newborn. The test will allow us to look for more than 50 different conditions. And as you can see the picture at the right, we are collecting 5 little spots of blood. It is not a significant amount of blood. It's quite a small amount, actually. But we're able to get a lot of information from those 5 spots. We've listed a couple examples of the types of things that we're looking for. So you can see ability for the body to break down proteins. That's a condition like PKU or phenylketonuria, which is, again, the first condition that was ever screened for in newborn screening, and was developed by a man who is from Minnesota named Robert Guthrie back in 1961. So we all started this whole program with that one test, but we've added a number of other conditions. So some of the conditions we look for, like MCAD, look at how much energy the body makes. We look for immune system issues like SID, which stands for Severe Combined Immune Deficiency, sometimes referred to as bubble boy disease. That's a condition where a baby does not have an immune system, and so being around people can be very challenging, obviously, for that child, and can cause death if we don't identify those children before their first infection. We look for conditions like cystic fibrosis that affect the breathing and digestion of that child. We look for hormone problems like congenital hypothyroidism. These are very easily treated, and actually congenital hypothyroidism is the most common condition that we will have a positive newborn screen for. And we look for issues with the blood, such as sickle cell anemia or sickle cell disease. The reason that we look for these 50 specific conditions is because all of these disorders that we screen for are treatable, but usually are not noticeable until a health problem has already occurred. The screen is our way of getting this information and being able to address the problems that that child develops before they actually have any problems or consequences from having the condition. If untreated, these different disorders can cause disability that's permanent, cause cognitive impairment, and in very severe cases, they can cause death. So they are very serious conditions, and when families have questions, that's how we try to talk about it, is that we can all of these things, but all of these things can cause significant problems if they were to go undetected. So then oftentimes, the next question is, well, how do I get these results? If a sample is collected between 24 and 48 hours and then mailed to the Department of Health so that we can do the testing here, the results are often not available until 3 to 7 days later, and families have gone home from the hospital at this point in time. With a positive result, the Department of Health will actually find and contact the primary care provider for that child. That's usually done by a genetic counselor like myself, where we will speak with the clinic, we will speak with the clinician and let them know what was found and what next steps need to happen for the family, and the provider will contact the family. The reason that we use that method is because providers actually have a relationship with these families, and they can see them in person and answer their questions. So we are a resource for the providers in this situation, and very rarely will we actually contact the families directly. Under results, we simply will generate a report. The Department of Health will send that back to the birth provider or the birth facility. So if a baby is born at Abbott Northwestern, for example, that report will be mailed back to Abbott Northwestern, and it's the responsibility of the facility to make sure that that information gets to the pediatrician or the primary care provider for that child. So if families ever indicate that they haven't seen their results, we really encourage parents to ask their provider for the results at their first well child visit, and that way they can make sure that the report's been done, that everything came back normal, and that there's no additional follow-up that would have to happen in that situation. To tell a story of how the people on the ground, such as yourself, really make a difference for us. Given I'm located here at the Department of Health, I can, toot my horn as much as I want about the wonders of newborn screening, but I'm not the person who's actually in there seeing clients and talking to them about what newborn screening really is and why it's a beneficial service. So we like to tell the story of Everett. Everett's mom had initially refused screening because she had heard at a church group that there were some concerns that people had about newborn screening and what was happening with blood spots or wasn't happening with blood spots. But she heard some conversations and felt a little concerned about it, said she'd look into it later and never did. So she shows up to have her baby and has a beautiful little baby boy, Everett. The nurse comes in and says, we're going to go do the newborn screen now. Do you have any questions? And well, I'm not going to do that test. I don't want to do it. So the nurse says, well, let me give you some information, and I'll come back in and we can chat more about it. So the nurse gives her some information and leaves. The nurse comes back a second time and says, well, how about now? Do you think we could do the newborn screen? And says, I still really don't want to do the newborn screen. I'm not comfortable with it. So the nurse says, why don't you think about it a little more and I'll come back. So comes back a third time. And at this point, the mom says, she very pleasantly wore me down. And I finally said yes. So then let the baby have his newborn screen. We received that specimen at the very beginning of day 3 of Everett's life. That afternoon, we had a positive result on Everett for a condition called galactosemia, with a condition where breast milk or milk that we drink, cow's milk, can actually poison a child to the point where it can actually go into coma and die from it. And the treatment is very simple. You switch that child to soy. But I reported that out to the doctor on the 3rd day of life. The child was seen very early in the day on the 4th day of life by the primary care provider and had just begun to show symptoms of this condition. They were able to switch his diet. He has only had soy. Since then, he hasn't had any normal milk or breast milk. And he's now a healthy, happy 5-year-old boy with no consequences or long-term issues because of the galactosemia that he has. So we always like to tell this story and show that a little persistence save a life, and a little bit of information really makes a difference. So that's where you guys, again, are feet on the ground, or soldiers on the ground, who are able to spread the word about how newborn screening makes a difference. And even if people don't think it can happen to them, most of these conditions are things that hide in families, and we would never know we had a family history of, or we don't. And they just appear. And so this mom clearly didn't think that she was at risk. She didn't think she was doing anything negative, but this changed Everett's life, and a very big difference for this entire family about what their life looks like. Hearing screening is done at 12 hours of age or later, and that can be done by 2 different methods, depending upon the birth facility and what they prefer to do, but OAE or ABR are 2 different ways that we can check for it. And we're looking for hearing loss hearing loss in the range where speech is heard. The reason that we do this is because early detection and intervention can help babies stay on track with speech, language, and communication skills. We know that language is integral in how a baby's brain develops, and so it can be important for them to have some ability to communicate. A few things that people often don't know is that infants can actually be fit for hearing aids as young as 1 month of age. And there are some families that struggle with the financial component of hearing loss diagnosis. diagnosis. And the Lions Infant Hearing Aid Loaner Program actually will loan out hearing aids to families that are trying to get their finances in order and figure out, what is insurance covering and what aren't they. So financial issues should never be a barrier why a child isn't being followed up on for their hearing screening, and any local audiologist would be able to talk to you more about the Lions Infant Hearing Aid Loaner Program. So if you ever hear a family have hesitancy because of that reason, let that there are options available to really help make sure that the child gets the screening or the intervention that they need. The nice thing about hearing is that the results are on the spot. So if the testing is done, the nurse or lab technician who did that will actually review the results with the family in the hospital or the birth center. Two examples for you here of what hearing loss can really look like. This is a situation where there was late identification of a girl who had severe to profound hearing loss. And I'm going to let you guys hear her say the phrase that's written on the right. Oops. Second, sorry. Thank you for your patience. We'll try that again. Let me get that at the beginning for you. As you can see, she obviously has some difficulties in communicating and her ability to use language in a way that is easy for others to understand. I think it's safe to say that without the caption, it would be hard to know what was being said. Now, here's an example of a girl who has the exact same level or severity of hearing loss, but was identified through early intervention, such as the newborn screen.
I am Kristen, and I am 10 years old, and I go to Brookside Elementary School. My favorite subjects are math and reading, and when I grow up, I want to be a teacher.
So as you can see, the timing of that intervention made a very big difference for these girls, given that they both have the exact same hearing loss, but one was identified early, and we were really able to help enhance her ability to communicate with others. And I think it's easy to say that there's a significant difference between these two, and that's really the story that we try to talk about with families about why hearing screening makes a difference. The third component is pulse oximetry screening, and again, that's our newest part, and that's done between or after 24 hours of life. This is where we actually wrap a pulse oximeter around the foot and hand, and you can see those two pictures to the right showing an example of that. And screening for is critical congenital heart diseases, and we have 7 primary targets. Some of them can be detected prenatally on a prenatal ultrasound at 20 weeks, but some of these are missed, and we know that critical congenital heart diseases can cause death or is responsible for 30% of infant deaths. So the goal behind pulse oximetry screening is really to identify those babies early and get them interventions before they leave the hospital. We know that we can treat these different heart defects with surgery and other interventions, and so it really makes a critical difference for these families versus having a crisis happen at home when they're not in a medical facility that's ready to deal with it. These are again given on the spot, like the hearing screening, and then evaluation if a baby is not passing their pulse oximetry screening. Their evaluation would actually happen prior to discharge, where they'd have an echocardiogram and a consultation with a pediatric cardiology specialist to discuss if there's any sort of concern that needs to be followed up on. Again, this is the newest screen for us, but we'd like to share Nora's story. Nora was born on November 14th of 2014. She had a heart defect that was not identified prenatally, but was in fact picked up by this pulse oximetry screening before she left the hospital. By day 10 of life, she went in for her open heart surgery, and she went home finally on December 8th of 2014. Nora is now a healthy 3-month-old girl. She's doing very well, and she's an example of a baby who would have found anything prenatally. This testing is what saved her so that she wasn't in a situation where she was not in the hospital when she started to go into crisis. So she's really one of the first success stories of critical congenital heart diseases and pulse oximetry screening in newborn screening. So shifting gears a little bit to the legislative updates and what's new. So like I mentioned, we were sued a couple of years ago, back in 2009, and we lost the lawsuit, which settled in 2012. At that time, we had to go back and destroy all of the blood samples that we had. So any baby who was born between 2012 and August 1st of 2014, if had a normal or negative result on their newborn screen, we would have had to destroy the leftover blood spot by 78 days after we had received it. If they had positive results, we would keep that sample for 24 months and 1 week, and that was due to CLIA standards, so we have to have some accountability for our positive results. And then all of the results themselves would actually be destroyed within 25 months. So a baby who was 2 years and 1 month old, if the mother called me, when baby was 2 years and 1 month old and a day, if mother had called me to get those results, we would not have that available for families anymore. They would actually have to go back to their birth facility and try to see if they still had that in their system, because they're not required to destroy those results. The legislative body made some changes again this spring, and as of August 1st of 2014, we are now allowed to keep samples indefinitely, and we're able to store those results indefinitely. So from August 1st going forward, any family that wants to get their results, if they're not able to get it through their primary care provider or their birth facility, would be able to contact someone like myself and get that information from the Department of Health. As screening for the hearing results goes, obviously we don't store any samples, so we don't have to worry about that, but they were exempt from this lawsuit that we went through, and therefore they store results until a child is 18 years of age from their date of birth. So that information would be available to families. Remaining blood spots is one of the big issues and what brought about the lawsuit. So people sometimes will have questions about that, especially people who are hesitant about newborn screening. We have a very small amount of dried blood that remains after this testing, but what we are able to do are a number of things. We store that in case we need to do additional follow-up testing. It also helps the laboratory with quality assurance and test improvements and development of new tests that might be added to newborn screening. But consent is now required for any sort of public health research that might be done. So families will be notified in those situations and requested. Parents have options in our state. Not every state allows options, but in the state of Minnesota, we are an opt-out program, which means that newborn screening is a standard of care for all Minnesota newborns, in that they should be offered the opportunity to have it. But a parent can choose for any personal reason to not have this test done if they want, and there are forms that they would need to sign that are available on our website. The different opt-out options that are listed below, people refuse for a number of reasons. Sometimes they want to refuse everything, the entire screening, all of it. Sometimes they would like to have screening done by a private laboratory, and if a family is interested in doing that, they're more than welcome to. They just need to be informed that the responsibility is on them to facilitate that process and get it all set up, and so it would be their job to make sure they come to the hospital with that information about how to do that. Families can request that we destroy the blood spots and the results or hearing screening results, so they can always contact us later and say, I'd like this information to be eliminated. They consent to be involved in research, or if they were, they can obviously take that away. Prior to August 1st of 2014, they could choose to extend how long we could keep the sample if they were so inclined. And can also request to have the blood spots returned to them. We work through the primary care clinics to make sure that we're being as safe and responsible of people's privacy as we can be. We're not going to mail it back to a house, but we will mail it back to a primary care provider and work with them to get that to the family if they'd rather have the blood spot in their hands. So what's the role? So that's the real question. We've given you a lot of information about what newborn screening really is, but how do you incorporate this information into your conversations with your clients? So we have another poll, and we're asking, do you currently discuss newborn screening with your clients at this point in time when you see them in the prenatal period? And A is yes, and B is no. So we'll take a little bit of time to answer that. Again, don't forget to press the submit button. Close the poll. Maybe going to close the poll. So it looks like around 54% of you are actually already talking about newborn screening, which is wonderful, and we appreciate that. We would obviously love to see that number get even larger. And I think part of it is that people didn't quite understand, is this my job? Should I be talking about it? And what should I say? We actually did a poll a survey this summer of prenatal providers and of parents that recently became parents to ask what is currently happening as far as newborn screening education in the prenatal time frame. And it's overwhelmingly really want to hear about newborn screening in that prenatal time frame. They hear about it from multiple people, and they really would like us to target the third trimester when we're giving this information, rather than just focusing on the labor and delivery time frame, which is, I think, when most parents were getting information from what we saw. So we really would encourage you guys to have these discussions with your clients. And again, the third trimester seems to be the most ideal time frame, but if you want to bring it up a couple times, we're okay with that too. Prenatal education, again, show that parents prefer to learn about it in the prenatal time frame rather than in that busy, chaotic time frame after delivery. Multiple professional organizations are encouraging that you have these discussions, including ACOG, ADMG, AAP, and HRSA. March of Dimes is also in cooperation with us as well, and they really encourage these conversations to happen. And look at the Minnesota statute actually regarding newborn screening. We are encouraged to provide you guys with the ability to be able to have these conversations. So the legislature has decided that this is an important time frame as well for us to be having these discussions. We have a number of materials available for providers that specifically target the prenatal time frame, and all our materials are available free of charge. We have these nice folders that you can see in blue with the woman holding her belly on the front. That's a provider folder that basically talks you through the details of newborn screening. And the little piece next to it, that newborn screening for parents to be, a little brochure that you can hand to the parents when you're having the conversation. And it gives them just a quick reference and some places, some links they can go to if they have more questions later. Again, we would love this to happen before the baby comes, ideally in that third trimester. We'd like the conversation to happen at least once, but if you feel so inclined as to do it more often, that's fine. And then a brief overview of newborn screening. Again, encompasses all three components, the blood spot, the hearing, and the pulse ox. Why it's important, what parents can expect as far as results or what the testing actually includes, and then answer any questions that parents might have, address their concerns, and you can also refer them to our websites and the resources that we have available. So here's an example of a mock conversation that you might be able to have between your clients and yourself regarding newborn screening.
Well, I think we've covered almost everything for today's visit. There's just one more thing I wanted to touch base with you about before the big day. Have you ever heard about newborn screening before? No, I don't think I've heard of that. Okay. So it's one of those things that's good.
Sorry, we're going to see if we can improve that volume for you real quick. I apologize. We don't blow your ears out. Let's try that again.
I think we've covered almost everything for today's visit. There's just one more thing I wanted to touch base with you about before the big day. Have you heard about newborn screening before? No, I don't think I've heard of that. Okay. So it's one of those things that's good to learn about before birth rather than in the hectic hours following it. It's 3 screens that's done on every baby in Minnesota, and we do them so that we can make sure that a baby's healthy before they go home. Here is the pamphlet. So the first screen is what we call the blood spot screen or the heel prick. And someone will collect that from the heel and it will go to the lab and we'll look for over 50 different disorders that have some sort of treatment or cure. They're all very rare, but they can cause health problems early on. And again, these are all things that are treatable. The second screen is the hearing screen, and that will check to see how your baby responds to sound. We know that hearing and sound are important in brain development, and so babies that have a hard time hearing can have issues in how they develop. When we find this early, then a baby's doctor can help to make sure that a baby has hearing aids or other resources and supports that are available to help as much as possible. Finally, the third screen is called the pulse oximetry screen. It checks to make sure that the baby's heart is healthy. All heart defects can be found prenatally, and so this is just a good way for us to make sure that baby's heart is healthy before you go home. Do you have any questions about any of these screens?
Well, when will you know if the screen found any issues or problems?
Good question. The pulse oximetry screen and the hearing screen, you'll find out right away. So the baby's nurse or doctor will tell you as soon as the test has been done what the results are. With the blood spot, the final copy of the report will be mailed to your baby's doctor within a couple of days, and they'll let you know if there's any problems that were identified. The first well child visit is a really good time to follow up with your pediatrician to make sure that the result is in and to see if there's any concerns that were identified.
Okay, that's good to know. And when I'm at the hospital, do I have to do anything to make sure my baby is screened for these tests?
No, actually. It's something that's considered standard care in Minnesota. We have about it so that parents know that it's happening, but again, all babies will have this done. And you can take this handout with you so that if you have any additional questions, you can read it later on. I'm also happy to answer any questions that you have, and also this website is a really helpful website. They have lots of really good information there.
Great. Good to know. Thank you so much.
So again, it's just an example of what we think might be the critical pieces for you guys to want to communicate to your clients. Brings us to our last poll. Do you feel that you'll be able to incorporate a conversation about newborn screening into your home visits with your clients? And A would be yes, and B would be no. So we'll just a little bit of time here. Answer that. Again, please be honest, because if not helpful, we can find other resources that help make it even easier for you.
Sort of blows my mind that parents choose to opt out. Yeah. No, I only have one.
So we close that poll. That's great to see. I'm glad that you guys think that this is information that you can incorporate, and obviously that's our goal by talking with you today. We think that it's important for families to have this information and be informed and we can hold that.
I think, yeah.
Okay. So again, we are continuing to make more and more resources for you guys, and if there's anything that you think would help ease the conversation for you, please let us know and we can develop that. So now we'll open it to questions. And I think a couple might have come in. No longer muted so that you can ask questions. It looks one of the questions that was sent to us is, how has pulse oximetry been included on newborn screening? The law for that passed in 2012, and we implemented that in 2013. It's something that all birth hospitals are doing, but it's not, so it's being universally done, but it's not being universally reported back to the Department of Health yet. So we don't actually have the statistics on it. We are currently rolling out a new electronic system called MinScreen that will allow us to collect hearing screening and pulse oximetry screening results electronically, and that's being rolled out to this Minnesota really throughout this year. So we don't have a ton of numbers, but that's been done since 2013. All hospitals do include it, and those that don't, very small, like midwives who aren't able to do it, they are instructed to make sure they talk to their clients about it or their patients and send their patients to the nearest facility that does do it. So all patients know, all parents would be informed that it's something that is available and should be done. What do you guys have? You can or talk to them. Questions about the resistant client, whether or not they talk to a person who says that they don't want newborn screening. And obviously a lot of that depends upon the reason why a person is declining it. But we see your job as the person to engage in a fight or an argument with them, but more to provide them with the resources so that they have some information that's based on what I consider fact, that they have some information and that they have the ability to go and get more information on their own time. So don't feel like if a parent's dug in or a client has dug in and said that they don't want it, don't feel like it's your job to obviously push it upon them. We just want to make sure they've heard the words and that they know that there's information available in case they're looking to educate themselves. People are always going to make choices that we don't agree with, but our goal is just to make sure that being a vehicle of information for people. Questions? Thank you so much for your time. I think we're going to take a quick break here and then transition over to the immunization part, but we really appreciate it. I will have London send out my contact information afterwards so that if you guys have any follow-up questions you'd like to ask me one-on-one, I'm more than happy to do that for you. And thank you again for your patience and your time.
Thank you, Maggie. Your presentation highlighted some really important conversations home visitors can have with their clients on newborn screening. As well as shared some important educational materials and resources for us to use. We take a short stretch break as we prepare for our next speaker. Please join us back here in 2 minutes. Thank you.
has been muted. To unmute your line, press *6 or #6, and you will hear a slight tone when unmuted.
Okay, and welcome back. Just a reminder that if you have questions during the next presentation, please submit them via the chat window at right, or wait until after the presentation and ask during our verbal Q&A. Now, again, your phone lines have been muted. Next, we have Bada presenting on immunizations and pregnancy.
I guess it's still good morning. We're not quite at the noon hour. I'm going to spend the next part of this hour talking about immunization information and key messages that the family home visitor can have tucked in the back of their head as they make visits to their clients. So we're going to be going over some specific vaccine recommendations that exist for pregnant women and why they are needed. I'm also going to discuss some general information about immunizations and how a family home visitor can insert supportive messages about immunizations with the expectant mom. And we're going to generally discuss how to respond to clients who seem hesitant about immunization. And just again to reemphasize the fact that we really do appreciate the role that you play in providing ongoing preventive health care and preventive messages to the clients that you serve. You are the ones that are in the best position to reinforce these messages and ensure continuity of care and provide reliable resources that can bring a mother into the best possible outcomes for her and for her infant. What are the immunization messages that I think you should kind of hold on to? And there are three key messages that are important, and these are ones that, as the opportunity arises, can be stressed to your client. And again, these are all folded into a lot of those preventive messages you're already providing. Immunization is one of the many things a woman does to keep herself and her unborn child healthy. And so, and I think that there are a lot of things that we think about when we think about a healthy pregnancy, healthy diet. There are certain things that we stop eating or drinking or stop doing. And immunization should be tucked into that message as just one additional thing that a woman does to keep herself healthy. Immunizations during pregnancy actually not only protect the mother, but protect the newborn. And we'll talk a little bit more about that in a minute. And immunization of a child actually begins in the prenatal period and continues throughout a person's life. So vaccines, this is your first polling question. What vaccines are recommended during pregnancy? And again, you can answer these questions to the right of your screen. And don't forget to press submit once you've picked your answer. We're down to the last 10 seconds. a lot of you are either already looking at your handouts, or you could be teaching this as well. There are, did a very good job. It is tetanus, diphtheria, pertussis, and influenza. So answer B was correct. And our recommendations that are actually supported, endorsed by the American Congress of Obstetricians and Gynecologists. And for those of you who, parents who want to know more about why they would recommend vaccines during pregnancy, this website, the link is listed at the bottom of the slide, is a really nice way to refer those searching mothers, those mothers who want to search for their information. So this is a real good resource for them. So one of the main vaccines that's recommended during pregnancy is the influenza, or we call it flu vaccine. And we talk about influenza, we're talking about respiratory influenza, not stomach flu. And this is a common misconception about influenza. When people think of flu, they think about stomach flu, but respiratory influenza is the virus that we're trying to prevent through immunization. And the reason why we are looking at influenza vaccination during pregnancy is because we see that influenza is not a mild disease, particularly in pregnant women. When you compare the rates of hospitalization and severe side effects or adverse events from influenza disease, women tend to have more rates of hospitalization. Women who have flu have a higher likelihood of going into premature labor. There is a likelihood that the infant, the unborn child, will be infected, and there's some data out there that is beginning to see that there may be long-term effects of being exposed to influenza virus while a person is pregnant. And then there are other complications that could potentially lead to death. And we saw some very chilling information during the pandemic H1N1 and its effect on pregnant women. So this is a disease that can be horrendous during pregnancy. And so we really want to make sure that if the woman is pregnant during the flu season, that she does get the flu vaccine shot. The nasal spray is not recommended during pregnancy, and that's because of theoretical reasons. The benefits for flu vaccination is that it prevents flu, which can be severe. We've talked about that. It protects the fetus. It protects the newborn as well, because the maternal antibodies that the mother develops will be passed on just prior to birth to this infant, and so it does provide added protection for that infant before that infant is able to get vaccinated. So, a polling question: TAP should be given in every pregnancy, true or false? So we have a little bit more diverse response to this. Some of you answered false. The answer is true, but this is a new recommendation, so it doesn't surprise me that we had this variety of answers. This is a vaccine that is recommended in every pregnancy. It's the pertussis component that we are focused on as the core of this recommendation. The tetanus, diphtheria, pertussis vaccine, which is also called Tdap, is given usually between 27 and 30 weeks gestation. And again, it's given in every pregnancy. And the reason we give it in that time period is in order to allow the antibody to build up and then be passed on to the infant. And certainly if it's given earlier or later, that's not going to be a tragic thing. It's just that that's kind of the target time. And benefits include protection of the mother against tetanus and diphtheria and pertussis, which we also call whooping cough. And again, this also protects the newborn because the mother passes those antibodies on to that infant just prior to birth. So again, we've got two vaccines that benefit both the mother and the infant as the maternal antibodies get passed on. So why do we recommend that Tdap for every pregnancy? Well, what we're learning about the pertussis vaccine is that the antibodies after you get vaccinated rise very, very quickly, and I've just depicted a very gross chart to show you that. And as those, in order for the mother to pass on those antibodies to the infant, they have to be at a certain level. They have to be pretty high. And usually within about a year after vaccination, those antibodies really begin to fall off very quickly. And while the mother will still remain protected, the antibodies just aren't circulating widely enough in order to be passed on to that infant. And so that is the rationale for why we are recommending that this happen in every pregnancy. There's some other vaccines that might be recommended for a woman during her pregnancy. And again, this is really very person-specific and something that a clinician would be discussing with that mother during their prenatal visits. Hepatitis B is a possibility if the mother is susceptible and has risk factors that would increase her risk for getting hepatitis B. Pneumococcal vaccine is another vaccine that's given to persons with chronic medical conditions, and sometimes if the person hasn't really been to the doctor except during her pregnancy, they may take the opportunity to give her this vaccine. If for some reason the woman is going to be traveling, particularly traveling outside the United States, hepatitis A is another vaccine that might be considered. And same is true for meningococcal. Travel would be the primary reason this vaccine might be given. But also, if there is a community outbreak, it would be recommended, and this would be a vaccine a pregnant woman certainly could receive safely. And then again, international travel to areas where there might be circulating polio disease, polio vaccination would be recommended. There are some vaccines that should wait until after the woman's pregnancy is completed, and that includes the live virus vaccines. And again, are recommended for waiting because of a theoretical risk. All of the studies that they've done looking at times when a woman has been given these vaccines during pregnancy, they have not seen any increased harm to either her or her infant. But in order to just maintain that safe vaccine program, those experts have recommended just waiting until after the pregnancy. And so include measles, mumps, rubella, varicella, the nasal flu spray is another one that you probably want to wait. And there may be a couple travel live vaccines that you would wait again until afterwards. Let's talk a little bit about immunization in the infant. And as I've said twice now, so I get to say it 3 times so you can remember, immunization begins with the maternal transfer of antibodies. So really, you begin that immunization process of a child in utero. It only occurs, though, if the mother-to-be has been vaccinated or had the disease. So a mother can't pass on antibodies if she isn't protected herself. And it's also important to stress that this is short-term protection. So what we're doing is passively immunizing that infant. That protection, those antibodies do begin to disappear, and some very quickly, and some take a little longer for them to decrease. And some diseases that a mother actually provides protection to her infant for include pertussis, influenza, and those can be through vaccination. Those, chickenpox, tetanus, and hepatitis A, just to name a few. Another key message that I think is really important for you to have tucked in the back of your mind is the purpose for vaccines. And really the reason why vaccines have been created, invented, and put out there is to prevent suffering and death. And we have been fortunate now to have developed vaccines that routinely protect us against 14 diseases. And of those 14, 13 are actually given within the first 2 years of life. And I know that a common complaint of some parents is it's just too many. We're just going overboard. And I keep thinking, this is great. As a person who used to take care of young children in an intensive care unit, there are some diseases that I used to fight to save a child's life against that parents don't even have to worry about, and many have never even heard of them. So this is actually good news, and we have very good technology now for a lot of vaccine development. So these are things that take advantage of a very agile and ready-to-learn immune system of a brand new child. So, and speaking of that, babies do receive their first vaccine as a shot, so their actual vaccination, within a few days of birth. And we create schedules to match up with baby appointments, and they're usually at 2, 4, 6, 9, 12 to 15, and 18 months. So these are the times when immunizations generally occur. And these diseases, this is a checklist of all of the diseases that vaccines can protect us against. While this sweet little girl looks pretty miserable, I have some little faces of some of the devastation of what these diseases can cause. These highlighted ones are the vaccines, again, that are received in the first 2 years of life. So, we have here with whooping cough, or pertussis. This is a disease that can cause a spasm of coughing to the point where it can last for 1 to 2 minutes and can cause a child to turn blue in the face. Infants who have whooping cough don't go into those spasms. They just stop breathing. And this is a very deadly disease for children under a year of age. And vaccinating the mother during pregnancy can protect that infant in those very early months until they can be vaccinated and build their own immunity against this disease. Staph infections is a common complication of chickenpox, and we see chickenpox as often quoted as something that a child should normally go through. Well, the devastation that can occur from chickenpox is staph infection. It's a common complication. And in the pre-vaccine era, over 14,000 children ended up in the hospital because of chickenpox complications. We don't see that anymore. Polio is a disease that's been eliminated from North America and South America. This whole Western Hemisphere has not seen polio as a wild disease any longer, and we are close to eradicating this globally. This is a disease that our grandmothers and grandfathers dreaded, and a disease that we really have no knowledge of any longer. A woman was a woman who was infected with hepatitis B when she was born. So during the birthing process, she was exposed to hepatitis B from her mother, and she developed a chronic disease, which can happen in infants up to 90% of the time. Of those infants who develop chronic disease, about a quarter of them will go on to develop liver cancer, which has happened to this woman. She's in her early 30s. She died about 3 months after this picture was taken. So this is not a pregnant woman. This is a woman who has a liver that no longer works. And hepatitis B can be prevented if we give that birth dose. This young adult is a person who shows the sequelae of a very, very invasive disease, which tends to be much more invasive during the adolescent years. We do have a vaccine that can protect our adolescents. So we're going down the 2 years, but again, vaccination is a lifetime process, and there are many stages of our life where we need to be vaccinated. Measles isn't just a rash. It is a disease that often causes pneumonia, and pneumonia that can end up a child up in the hospital. And this is a child whose mother had refused the MMR, and he traveled with her to a country where there was measles circulating. He came home and then developed measles. He had been exposed about a week before his return home, and he was within hours of dying. He almost ended up on a heart-lung machine. The mother now tells her story to people, tell them that any fear that she had of the vaccine far away it pales in comparison to what this child suffered because of a decision that she had made. Finally, another disease that we don't see is infant effects of maternal rubella, or women who get German measles while they're pregnant. This is a very devastating disease that is now prevented by the measles, mumps, rubella vaccine. It's a important disease that gets screened during pregnancy, such that if a woman isn't showing that she's immune, she will get this vaccination, so that there's not risk to future infants that she might have. And the baby ended up with blindness from a rubella infection that happened while the woman was pregnant. So we do give a lot of vaccines. We had our opportunity, again, to prevent disease and suffering and death. And this is the schedule that is used to provide these vaccines, these many vaccines. How do they figure out this schedule? Well, first of all, this is a schedule that's determined by a combination of experts. It's a national advisory group, and they're made up of pediatricians and specialists in vaccine making, family medicine docs, infectious disease specialists, adult medicine specialists, which also include OBGYN specialists, and it also includes people from the public health arena. And they use data to make these recommendations, and the data comes from the clinical trials from the manufacturers. It comes from study and understanding the disease, who it affects, the severity of the disease, and they also look at the cost benefit. You know, should they be making a recommendation for everyone, or should they be making a recommendation for only certain at-risk individuals? They make recommendations for every single vaccine that is licensed here in the United States. So as they're making these recommendations, one of the key things they look at is timing. And if we go back to that schedule, you'll see that there are certain vaccines that are recommended during infancy, and then there are some that we don't give until they're maybe 12 months of age. So they time these when the disease is most likely to be severe or have the most severe repercussions. But they also have to time these so that a response that the person has will provide the best protection. And remember that we talked about the mothers passing on those antibodies to their babies just before birth. Well, some of those antibodies last until the baby is a year old. So back to that schedule, some babies won't get a vaccine until they're 12 months of age, and those include the MMR vaccine, the varicella vaccine, and the hepatitis A vaccine. So these vaccines that they're protected, or these are diseases a child's protected against, usually in that first year of life. But once they turn a year, right around that time, that's when you really need to continue that protection through active vaccination of the infant. The other thing is that they look at our dosing and frequency, and these are things that are determined by some of the clinical trials. Again, when a child's born, they breathe in thousands of germs, and their immune system kicks in right away and protects them. But sometimes their immune system is learning, it's developing a process of building that immunity. And for some of the vaccines, they need repeated doses to just keep priming and teaching that immune system to create those antibodies. And so for some vaccines, because of the type of vaccines they are, children need multiple doses of vaccine. And one of the things that I wanted to talk a little bit about was the hepatitis B and the timing of that first dose. Why a newborn? And I think the biggest argument against giving hepatitis B at birth is that parents don't believe their baby is at risk. Because what we know of hepatitis B is that it can be caused, probably the greatest risk is to people who inject drugs illegally or people who are very sexually promiscuous. And of course that's not happening at birth for an infant. There are some things that we need to understand about hepatitis B. Before there was ever a vaccine, about 6,000 infants were infected from their mothers. And about 16,000 children under age 10 developed hepatitis B infections. And sources of those infections were unknown. The other thing that's important to understand is up to 90% of infants that are exposed will develop chronic hepatitis B. This is a disease that the burden of the chronic illness actually lies in infancy. And by giving that hepatitis B birth dose, we start the process of protecting them against a disease that could wreak havoc in a person's life if they do get chronic hepatitis B. There are a lot of infants that don't have to have this, but again, because we don't know the point of exposure that they may have, this becomes a very protective, preventive disease for which a vaccine can provide protection. Other things about vaccines, how vaccines are given to healthy people. FDA holds the manufacturer to the highest safety standards when they are providing or developing these vaccines. These are vaccines that instead of doing trials on hundreds of people, the manufacturer is doing clinical trials on tens of thousands of people to ensure that these are effective and to ensure that these are safe for young children to receive. But we need to also be aware that no medication that we give, including vaccines, is 100% safe or 100% effective. There is rarely some times people who do have a reaction to a vaccine, just like people have bad reactions to medications. And there are people that don't respond to vaccines, even if you have made the effort to get them vaccinated. We do have a couple vaccines that don't work as well as other vaccines. Our flu vaccine is an example of that, where we improve our odds of protecting ourselves against flu, but it isn't at anywhere near close to 100% effective. Well, I do have another polling question, and I see that I misspelled polling here. Sorry about that. What disease has been eliminated from the Western Hemisphere due to vaccination? That's a little bit of a trick question. We don't see diphtheria much in the United States anymore, but people do carry that particular bacteria in the back of their nose and their throat. So it's been eliminated, and yellow fever is no longer here in the northern part of the Western Hemisphere, but it is still very much a disease of concern in the southern part of the hemisphere. So the answer was polio. And dengue fever is something that we're seeing a growing problem with, and they're actually doing some research to develop a vaccine for dengue fever. So we'll see what happens for the future there. Vaccines have been successful, and we've seen that. We've seen the eradication of smallpox from the world and the elimination of polio from the Western Hemisphere, and the disappearance of certain diseases like diphtheria and Hib and rubella and tetanus. So these wonderful things happen. However, sometimes we become the victims of our own success. And one of the things that we've seen is an increasing hesitancy about vaccines. And so why? And I think some of you may even have your own sense of that hesitancy in some of the conversations you might have with parents. The biggest reason, I think, is that we no longer fear what we don't see. If we don't see the disease or know the disease, what we do then begin to focus on is what's the present risk. And there's a lot of misinformation and claims out on the internet that create a fear about vaccines. And so we don't know how to weigh our risks and benefits when we don't see the danger of the diseases. Media has not done any service to immunizations, although I've been in my glory days over the last few weeks as they've defended vaccines, but that has not always been the case. And while the media hasn't been really oppositional against vaccine, they love to create controversy where there is no controversy. And like any of us who work in public health, seeing those the media being an arena for controversy when there shouldn't be. The other thing is that we've really been moving away from a scientific mind to a much more experiential type of mind, and facts become relative. We hear a claim and we're not challenging people to support the claims that people make, and we don't understand the importance of facts and of science and of the scientific process. And so all of those things contribute to people using a fear as the driving factor in whether their children are vaccinated rather than using facts to base their decisions. Key considerations here related to hesitancy. That most of the things that people are hesitant about are based on misinformation, that they haven't seen the disease. And the information source is that they're getting is not always reliable. And yet the parent believes that they have done research to make their decision. These decisions are driven by fear and fueled by the power of a scary story. Again, when you have a story about something that's happened, just as I told the story of the little boy with measles, that creates a perspective of how dangerous measles can be. But sometimes you will hear parents talk about, my child got the MMR and the next day they were autistic. And oftentimes parents lose the perspective of time. We associate things that happen in time to a cause, and it's just how it's our human nature to think illogically that way, because we are such a everything is relative thinking creature. We want to find reasons for why things happen, and it's the science that helps us sort through those that are real and those that aren't real. Another thing that's really driving this is an increasing distrust of institutions such as governments, the medical establishment, and pharmaceutical companies. And again, it's because in media, some awful stories have arisen about corruption or incidents that have occurred, and again, we lose the perspective of a few times that happened. It seems like it's happening all the time, and so we feel like we can't trust these type of institutions. And the other thing is, when a parent makes a decision, they're trying to do what is best for their child, and their focus is on their child and not looking at the broader community, because all they can see is the risk that it might impose on their own child. And understanding that possibly a vaccinated child not only protects their child, but also protects their playmates as well. So, true or false? Not every piece of information will suit a parent's information needs. We have steps we have to go through to get poll going. It's a no-brainer, isn't it? So you were right that it is true, not every piece of information is suited for all parents. Parents begin to make decisions about their child before their child is born. So we're trying to figure out ways that we can take that immunization message upstream. And what research has shown us is that parents make decisions differently. The bulk of parents are acceptors. That's why the majority of parents actually do choose to vaccinate their child. They accept their provider's recommendation because he is an expert. He knows what's going to be best for their child. And we have parents who rely on advice probably from people that they perceive are the closest to them. And peers are a really important part of a relier's decision-making process. And we've really seen this particular type of decision maker emerge as our social media connections have really increased. So the blogs and the Twitter and Facebook are all sources of feedback to these type of decision makers. And whether the peer is an expert or not is irrelevant for some reliers. If we can get these reliers into some really good information as they're making their decision-making process, it's possible that reliance on good information will drive their decision toward choosing to immunize. And then there are parents who do actively do their own informational searching. And again, if we can get them before they start their search and direct them to reliable sources of information, these searchers, they need to be owning their own decisions, but by getting good information, they can make a decision to support immunizations for their child. And it's important to know where parents are seeking information. Because again, as I mentioned, healthcare providers are still a trusted source of information, and healthcare providers can influence a parent's decision by making strong recommendations. Own parents can be a source of influence, although I have my doubts having two sons who make up their mind, and I have to use other people to advise them and rather than myself. And the internet is become a huge source of information, and as I mentioned, the information sometimes is very unreliable, and there's no accountability for what you post on the internet. And so a word of precaution to those of us, we want to make sure that we're directing them to good sources of information. So what can you do as a family home visitor to support this? I think we're not asking you to try and argue a person out of the hesitation. There are too many claims out there to develop any kind of expertise in that area. I'm still learning myself, and I've done this for 20 years. If parents raising a concern, acknowledge it. If something like this seems like it's something that really concerns you, encourage them to talk to their care provider. These are important things for them to have a conversation about, and if they need, have them make a special appointment to do that. As I mentioned, avoid arguing or intense discussion. It really just kind of makes someone dig their feet into their position. Explore where they've heard the information and encourage them to keep seeking information. And have one or two resources on hand for the parent. And I included a couple of these in the presentation handout. This baby brochure is really a good piece for the acceptor and relier. Give it, when the mom's around 28 or 32 weeks gestation. They're free. You can order them from the health department. It talks about what vaccines a baby needs. It talks about how the vaccines work, that they are safe, and it also addresses free and low-cost shots if that is a concern for the parent. Back, it also has some key critical resources for directing a parent who wants to do a little more searching. For the searcher, on the other hand, the handout is a two-sided handout called Reliable Sources of Immunization Information. Is a good piece to give to someone who is a searcher. It gets them started in the right direction, and they can pick what website they want to go to from these reliable websites. It also has publications if they want to read more about immunization. Another really good informational website for both the relier and the searcher is the Vaccine Education Center, which is hosted by Children's Hospital of Philadelphia. We have both question and answers about common concerns about vaccines, and they also have basic information about every one of the vaccines that we give to our infants. And again, for the searcher, an in-depth informational booklet that's free and available online and was produced by Seattle-King County is the Plain Talk About Child childhood immunization. And one of the things I like about that is their compare the risks, where they discuss disease versus vaccine. And again, for the searcher, this is meaningful information. So, messages to sum up. Pregnancy is a great time to learn about vaccines when there's less hectic life going on. Vaccines are made to prevent suffering and death. Vaccinating our children is the norm. Parents do have the power to protect their child from some serious diseases, but it's important to direct parents to reliable resources. A good analogy is just like a seatbelt. If you wait until you need a vaccine, it's often too late. Thank you. Any questions that you have, I'm happy to take. The line is unmuted.
The Outlook, I got two. I was the caller. I didn't know if it was just mine. What did you do? Just decline?
Reminder, their lines have been unmuted, so if you have questions, now's a good time to ask. Okay. You did an excellent job of describing the importance of immunizations and the steps home visitors can take in discussing them with families. Concludes today's webinar. Thank you again to Maggie and Lynn for your time in preparing and presenting these to the family and visiting provider audience. The chat window will close with the completion of today's webinar, but if you have any questions remaining, please email them to health.fhv@state.n.us. Have a wonderful afternoon. Bye.